Hi, and welcome to this webinar arranged by the National Academies of Sciences, Engineering, and Medicine's Roundtable on Obesity Solutions. Today's webinar will focus on the potential role of sleep in the prevention and management. Thank you for tuning in. My name is Scott Kahan. I'll be chairing today's webinar, a member of the Roundtable and a member of the Planning Committee for this program. I'm an obesity medicine physician and medical director of the Stop Obesity Alliance. Take a moment to recognize and thank the other members of the webinar planning committee. Shriki Kumanika from Drexel University, Dr. Bill Dietz from the George Washington University, and Dr. Elsie Tveres from Harvard University. Our speakers for today's webinar are Dr. Sanjay Patel from the University of Pittsburgh, Elsie Tveres from Harvard University, Mike Brandner from the University of Arizona, and Chandra Jackson from the National Institutes of Health. I'll show you the dozens of frankly not too funny jokes I can make about me needing more sleep, and instead we'll just get right into a few housekeeping rules and then onto the meat of today's presentation. First, the audio for today's event will be streamed through your computer speakers. We'll be taking questions through the Q&A box located on the lower right-hand side of your screen, and we enthusiastically encourage you to ask whatever questions you have on your mind as you listen to the presentations. Simply type your question into the box at any time and click Send. We'll ask you leave the box set to send your questions to all panelists. The webinar is being recorded. Please understand that any questions you submit may be allowed and included in our recording. A link to the recording, as well as a copy of the slides, will be posted on the Roundtable's website within the next week or so. And if you have any technical issues during the event, please contact WebEx Technical Support at 866-299-3239. The number for the technical support is 866-299-3239. Let me start with a very brief introduction. One central concepts we've learned over the course of the 3 years of the Roundtable is that obesity management and weight regulation is more complex than just telling someone to eat less and exercise more. This slide shows some of this complexity. The Conceptual framework by the Foresight Group in the UK showed that there's hundreds of factors and many hundreds of interdependencies between these that play into energy balance and weight regulation. We can simplify this a little bit here, and we see here the key categories that make up the conceptual framework. So energy balance are categories of factors that influence what we eat and what we move. We've spoken about many of these during the Roundtable workshops, things like the food environment, physical activity and the physical activity environment, social norms, and the others. Today, we'll talk about yet another, sleep deficiency, which can cause a range of physiologic changes that impact weight and health. So we're talking about that, largely about that category at the bottom of the screen, physiology. Back well over a decade shows a strong and bidirectional association between sleep and weight. In other words, those who sleep less or also significantly more than optimal are more likely to have increased weight, and those with increased weight are more likely to have inadequate sleep. So we're going to hear all about this relationship between sleep and weight, and in particular, we're going to learn some things about what we can do to address it. So with that, let me introduce our first speaker, Sanjay Patel. Dr. Patel is a visiting professor of medicine at the University of Pittsburgh. He's a physician scientist whose research focuses on the bidirectional relationships between sleep and obesity. His research has included studying the epidemiological relationships between sleep and obesity in large cohorts and identifying metabolic effects of sleep-related exposures on adipose tissue and obesity-related hormones. He is interested in using weight loss interventions to treat sleep disorders. He's the director of the Center for Sleep and Cardiovascular Outcomes Research at the University of Pittsburgh and also directs the Comprehensive Sleep Disorders Clinic at the University of Pittsburgh Medical Center, where he cares for patients with sleep disorders. Well, Dr. Patel, and I'll pass it along to you.
So, tasked with giving an overview of epidemiology of sleep and obesity risk. So I'll start by just making sure we're on the same page on what is sleep. Definitions, but one I like is that's the natural recurring state of inactivity associated with diminished responsiveness to the external environment, and it is rapidly reversible. I think it's important to note that periods of sleep as defined above occur in all multicellular animals. It's been shown to occur in insects like fruit flies and even in microscopic worms, this nematode. So why do we sleep? This is a question that we don't really have a great answer for, but there are a number of clues that we have. One is that there is a homeostatic drive to sleep, which means the longer we go without sleeping, the sleepier we get or the easier it is to fall asleep. And this suggests that there is some important role for it because our body is trying to ensure we get enough sleep. Second point is that there have been experiments in animals that show that with complete sleep deprivation, rats die in a few weeks, demonstrating that there is something important about sleep. So there are many potential explanations hypothesized about sleep. Most of them have focused on the brain, suggesting that sleep is important for restoration of the brain's activities. Hypotheses have included that sleep is important to provide time to rebuild energy stores after these have been depleted during periods of wakefulness. Sleep is important for memory and learning, and there's a lot of great science showing that connections between neurons are strengthened during sleep. Sleep is important for the clearance of neural waste products, again, that have accumulated during wakefulness. But there's also been a hypothesis that sleep is important not just for the brain, but for the body as well, in allowing time for physical restoration, including for different parts of the body, like the muscles and the immune system. And I think increasingly there's interest in the fact sleep may be important in allowing a restoration of balance of metabolism as well, and that may be the underlying reason for the issues related to obesity that we're going to talk about today. So, just a brief overview of how sleep is regulated. There are two main drives in the body to sleep. That homeostatic drive for sleep that I just described, where since the last time you slept, the sleepier you are, and the more likely you are to fall asleep. Is that there's a circadian rhythm for alertness, a 24-hour rhythm through the day, across days that regulates when we're alert and when we're sleepy, so that around the same time of day we're tired and feel like going to sleep, and the same time of day that we are most alert. That circadian clock keeps body processes and behaviors synchronized, not only sleep, but also feeding behaviors, body temperature, and hormone secretion. So there's a bidirectional relationship between sleep and the circadian rhythm that may be important when it comes to obesity. Sleep is obviously regulated by that circadian rhythm, as I just described, but also how we sleep may affect the circadian clock, because one of the most important regulators of that circadian rhythm is exposure to light. And when you're sleeping, of course, you're not exposed to light. So what sleep do we need? The data from the National Sleep Foundation that show recommendations for sleep by age. Newborns are recommended to sleep anywhere from 14 to 17 hours a day. As we get older, that the need decreases. Now that school children need to 11 hours of sleep for optimal health, and even teenagers need 8 to 10 hours of sleep. You get older into adulthood, that need goes down to somewhere between 7 to 9 hours. Those are recommendations are, how much are we actually sleeping? These data are from the CDC's Risk Behavior Survey looking at how much sleep teenagers are getting on school days. What you can see is across multiple years of surveys, the percentage of teenagers who are getting less than or equal to 7 hours, which by anybody's definition is insufficient sleep for an adolescent, is somewhere around 69%. So the majority of teenagers are not getting enough sleep on school days. If you how that varies by grade, you can see on the left-hand panel that the prevalence of insufficient sleep goes up from 9th grade to 12th grade. And then look at the distribution by race, you can see that Asian children are actually have the highest prevalence of insufficient sleep, followed by African American children. How have sleep patterns changed over time? They come from the Zurich longitudinal study in Switzerland, where they've looked at cohorts over many years, all of these children from birth up to age 14. And this analysis, you can see they divided the children into 3 groups: those born between 1974 and 78, born between 1979 and 1985, and born between 1986 and 93. And at each age, what you can see if you look at the bedtimes is that as time has gone on, beds have gotten later. So in the early 70s, at one age, the average bedtime was at 7:08 p.m., and that had gone up to 7:46 by the late 80s and early 90s. And that persisted as the kids got older. In contrast, the wake times have relatively remained constant over time. So as we've gone forward over the last 35 years or so, bedtimes are getting later, but wake times aren't moving. So overall, the children are getting more sleep deprived. So what about adults? So the prevalence, there are a number of large cohorts representative of the entire population of America that have relatively consistent results. You see here the Behavioral Risk Factor Surveillance System, National Health and Nutrition Examination Survey, or NHANES, both ask questions about how much people sleep on average. In both surveys, you see that somewhere around 35 to 37% of adults reported that they were getting less than 7 hours on a typical day. If you look at the distribution by race, you can see that African Americans have the highest prevalence of insufficient sleep. What's happened to adult sleep times as we've moved on in time? The data from the National Health Interview Survey, asking the same question about 20 years apart in 1985 and in 2004. And insufficient sleep was defined as less than or equal to 6 hours. They're plotted, stratified by both age and sex. But what you to focus on is taking any stratum, compare the 1985 results with the 2004 results. You can see that the prevalence of insufficient sleep has gone higher in each and every stratum, and suggesting we're getting less sleep now than we were 20, 30 years ago. There's been a lot of work on observational studies to try to understand what are predictors of short sleep in adults. And I've classified them into these categories. So one is demographics. There are these racial differences, and African Americans have been found to consistently get less sleep than other groups. When we look at objectively measured sleep, men tend to get less sleep than women. Amongst immigrants, acculturation has been shown to be associated with sleep. So people who newly moved to the U.S. tend to have better sleep habits than people who may have lived in the U.S. for some time, or the children of immigrants. suggests there's something about American culture that pushes people to sleep less. There's another important factor. Employment status is one of the strongest predictors of short sleep, and obviously long work hours compete for time to sleep. And in work shift can play an important role. People work night shifts where they have to be awake at a time their body wants to be asleep, have a hard time getting enough sleep. But is another important factor to consider. To show that people who live in cities get less sleep than people who live in more rural residences. Living in an unsafe neighborhood has been associated with less sleep and poor quality sleep. Having longer commuting times from where you live to work has been associated with having less time to sleep. There are individual choices, and screen time appears to be the strongest, and this is true both for adults as well as children. Time and watching television competes for time to sleep, and that's into other types of screens, tablets and smartphones and things like that. This issue becomes even more important. So here's a distribution of how sleep vary by geography. Data from the Behavioral Risk Factor Surveillance System. What's plotted is the percentage of Americans in each state that reported that they get enough sleep on 30 of the previous 30 nights. And what you see here is that the blue are the states that have the highest prevalence of insufficient sleep, and these are located primarily in the southeast and Appalachian states like West Virginia. Compare that to probably a lot of people have seen before, looking at the distribution of obesity by the Behavioral Risk Factor Surveillance System. You can see that the states that have the highest prevalence of insufficient sleep also have the highest prevalence of obesity, the Deep South and the Appalachia. And analysis comparing sleep and obesity data on an individual basis from the Behavioral Risk Factor Surveillance System show that there is a correlation that if you divide people by the level of obesity, the more obese someone is, the more days of insufficient sleep in the past month that they report. We looked at this longitudinally using data from the Nurses' Health Study, which is over 60,000 middle-aged women who reported in 1986 how much they slept. We followed their weight over time, and what I hope you can appreciate here is that in 1986, the women who reported getting less sleep, 5 or 6 hours shown in the red and green dots, way more than those who reported getting 7 or 8 hours of sleep in the orange and blue dots. On that, over time, all of these women unfortunately gained weight, but the rate that they were gaining weight was essentially higher in those who were getting less sleep. That red line is going at a faster rate than the orange and blue lines. Now, I mentioned that sleep duration isn't the only aspect of health that's important. In the sleep field, we've become more and more aware that we should think about multiple dimensions when we think about sleep health. Dan Macy at the University of Pittsburgh has proposed this 5-dimensional model of sleep health that includes quality or satisfaction with sleep, daytime sleepiness or alertness, the converse, time sleep. So whether you sleep earlier in the evening or are a night owl and go to bed late, sleep efficiency, which is what percentage of the time that you spend in bed you actually spend asleep, and finally duration. On these 5 dimensions, I think it's become more clear that we should also think about variability in sleep patterns. This likely reflects or impacts the strength of the circadian rhythm. So the more regular we are with when we sleep, the stronger our circadian rhythms are. A number of the other aspects of sleep health have been associated with obesity. Late timing of sleep has been shown in studies to be associated with increased intake over the day, as well as increased risk of obesity. Having highly variable sleep patterns has also been associated with obesity, and in children, this is most commonly seen in this concept of weekend catch-up, where children are sleep-deprived during the school day, and then on the weekends, they oversleep to try to make up for that. Time napping has been shown in adults to be associated with obesity. And shift work, as I've previously said, having people sleep at an adverse circadian time associated with not only obesity, sectional studies, but also longitudinally shift workers seem to gain weight at a faster rate. In addition to those dimensions, poor quality sleep and sleepiness have also been associated with obesity, but there's bigger questions about what direction of that relationship is, as I'll get into in a second. So we've talked about how sleep might be a risk factor for obesity. I want to just mention that obesity also impacts sleep. Obesity is, I think many people know, can cause a number of secondary consequences, all can result in disruption of sleep. Sleeping is probably the most one common sleep disorders, and the strongest risk factor for sleep apnea is obesity. On top of sleep apnea, though, obesity is commonly associated with arthritis, with low back pain, or pains in other joints that disrupt sleep at night. Obesity is a factor for depression. Both heartburn and asthma are exacerbated by obesity and tend to be bigger problems for patients at nighttime, where they keep people from being able to sleep. And then diabetes is almost universally associated with disruption of sleep, as both hypoglycemia and hyperglycemia cause difficulties with being able to sleep. So just note about sleep apnea. For those of you who are not familiar with this, this is a syndrome where there are repetitive episodes of obstruction of the airway. When try to take a breath, they generate a negative pressure inside their chest, and that causes air to go in through the nose, down the throat. But negative pressure also tends to cause the throat to collapse inwards. Obesity puts more tissue in that throat, and so makes it more likely that the throat will collapse. The sleep apnea has to wake up to open up their throat again, and so through the night their sleep is very fragmented and get into a deep, restful sleep. So these are just demonstrating that obesity is a strong risk factor for sleep apnea. These are from the Sleep Heart Health study. You divide up individuals by quartiles of their body mass index. You can see with the lowest mass index, or BMI, have the lowest prevalence of both mild and moderate to severe apnea, and those prevalences rise as the obesity level goes up. In terms of rate predisposition to sleep apnea, you can see yellow bars that African Americans have a much higher risk of sleep apnea. But Hispanics and Asians also have a higher risk than whites for sleep apnea. Look at percentage have actually received a physician diagnosis of sleep apnea. However, you'll see that blacks and Hispanics have a similar rate of getting diagnosed as whites, despite having a higher overall risk, suggesting there's a disparity in getting diagnosed. In Asians, you can see the diagnosis rate is much lower than whites, even though the prevalence is much higher. So I just want to point out that independent of these secondary conditions like sleep apnea, depression, and diabetes, obesity appears to be an independent predictor of sleepiness and fatigue. And these are from the Penn State cohort in Hershey, which is that as the mass index goes up, the risk of having excessive daytime sleepiness goes up as well. you can see that amongst those with the BMI less than 28, the prevalence of daytime sleepiness is about 6%, but those with the BMI above 32, the prevalence is over 12%. A lot of data show that obesity is associated with inflammation. It's believed that some of these inflammatory cytokines can get across the blood-brain barrier, and things like necrosis factor, TNF, and ICN1 get into the cerebrospinal fluid in the brain, known to cause the brain to become sleepy. And so it's thought to be one of the mechanisms by which obesity causes sleepiness and fatigue, which secondarily affect things like physical activity. So why don't I conclude with these poor sleep and obesity are closely associated, have these bidirectional relationships. Obesity has occurred contemporaneously over the last 25 or 30 years with a reduction in sleep. Minorities, particularly African Americans and Asians, are at greatest risk of poor sleep. Other important factors contributing to poor sleep include work and school requirements, place of residence, and screen time. So let me end it off at this point.
Thank you, Dr. Patel. That was fantastic. And now we'll hear from Dr. Elsie Taveras. Dr. Taveras is Chief of the Division of General Academic Pediatrics and Director of Pediatric Population Health Management at Massachusetts General Hospital. She's Associate Professor of Pediatrics and Population Medicine at Harvard Medical School and Associate Professor of Nutrition at Harvard School of Public Health. Dr. Taveras is a pediatrician and a childhood obesity researcher. Her main focus of research is understanding determinants of obesity in women and children and developing interventions across the life course to prevent obesity, especially in underserved populations. Her work spans the spectrum of observational studies and interventions to identify and quantify risk factors and to modify these risk factors for health promotion and disease prevention. And before Dr. Taveras gets started, I'll just note again, please feel free to put your questions into the question box and send it along, and we're going to get to them at the conclusion of the four discussions. So Dr. Taveras, please.
Thank you. Thank you, Sanjay. That was an excellent overview, and for those on the webinar, you'll see a lot of some similar themes in what I'm going to present, which is really focusing in on sleep and its association with childhood obesity and weight gain. I'm going to talk a little bit about the patterns of childhood sleep duration in the U.S., although Sanjay covered that very nicely, so I won't spend too much time on it. I'll describe the state of the science and research gaps relating insufficient sleep to overweight and obesity in infancy and early childhood, just mechanisms relating sleep to obesity in children, and end by summarizing interventions have been conducted, including some from our group, to improve sleep for obesity prevention. And there are some really interesting studies look at secular trends in childhood sleep that also show that the rising prevalence of childhood obesity is paralleled by the secular trends of shorter sleep durations in children, as it also looks to be true in adults. In an analysis of almost 700,000 children from 20 countries going back over 100 years, the study found that on average, children today sleep about 20 to 25 minutes less each day than their parents did when they were the age. And from the study that Sanjay presented, it's very clear that across childhood, it's like that decrease in sleep duration over the last 20 years is due largely in part to later bedtimes with fixed wake-up times, and wake-up times not shifting over that time. So when we look very specifically at patterns of sleep duration in children, what this figure shows is that children, infants, and toddlers in lower 25th percentile of sleep, so the lowest quartile of sleep duration, the infants and toddlers who are getting the least amount of sleep, there's some really good evidence that show that those children are more likely to be put to bed asleep, fully asleep, versus drowsy and awake, and some suggestion that that's affecting the infant's ability to self-regulate their own sleep patterns. Among slightly older children, those in the lowest quartile of sleep duration are more likely to share a room or a bed, more likely to drink caffeinated beverages during the day, and likely to have a screen, in this case a television, in the room where they sleep. Among adolescents, this shows the amount slept on school nights versus sleep needed. And what you can see is that only 1 in 5 adolescents get an optimal 9 hours of sleep on school nights. Over adolescents say no, they get less sleep than they need to feel their best. And nearly all adolescents have at least one electronic item, a TV, a computer, a phone, or music device in their room. And becoming even more common are screens that allow notifications at night, which is another contributor to sleep quality in children. There are several studies now that have looked at the relationship between sleep and obesity in infants and children. In a systematic review by Hart et al. In 2011, they had 29 studies conducted in 16 countries that suggest that short sleep is associated with an increased risk for being or becoming overweight or obese. Later bedtimes is also a risk factor for overweight and obesity. There's some debate about the relationship between sleep and obesity. Some have reported inverse associations between duration and adiposity. Others have had null findings, and at least one randomized controlled trial of an infant sleep intervention did not have an effect on future weight. In studies in infants as early as 6 months of age, we found that in multivariable analyses, infants 6 to 2 years of age or under 2 years of age who slept less than 12 hours per day had higher body mass index Z-scores and increased odds of obesity. And this is similar to some of the cross-sectional studies and other longitudinal studies in infants that related short sleep duration to increased weight gain and obesity. The study that we conducted children in the middle school period, so from about 7 to 10 years of age, we found that indeed chronic insufficient sleep associated with higher BMI Z-scores in mid-childhood. In this study, we looked at a score to determine how often children were exposed to optimal sleep duration. As you go from 0 to 13, on the x-axis here, you're going from maximum exposure to chronic insufficient sleep to very little insufficient sleep at 13. And you could see that the highest body index Z-score is among children who had multiple exposures from 6 months of age to 7 years of age of insufficient sleep. A little bit Sanjay did about some of the potential mechanisms relating sleep and insufficient sleep to obesity. And also by Hart and her group, there are some interesting potential mechanisms reported for slightly older children, so not necessarily in this case reporting findings in infants. Some mechanisms are those that you heard they already mentioned. There are studies that show that insufficient sleep may alter appetite hormones such as leptin and ghrelin. Interesting studies also that have looked at the role of insufficient sleep in appetite dysregulation, affecting hunger and satiety, and also affecting and influencing energy intake. That have also been shown in children that have looked at insufficient sleep leading to more opportunities to eat. And we talked a little bit already about the role of television viewing and the role that television plays in substituting sleep time. If that replacement is time that allows more opportunity to eat, it can influence also energy intake. Some of our own studies we have found in children, worst combination in terms of body mass index, Z-score, and BMI gain among children who sleep too little, in this case less than 12 hours per day, around 3 years of age, and watch more than 2 more hours of television per day. There's really evidence showing that this combination of too little sleep and too much television is particularly risky for weight gain in children. There's really great research emerging looking at the role of sleep and insufficient sleep and its relationship with executive function in children, executive function and neurobehavior. So studies, including of our own, that have shown that insufficient sleep in children may alter mood, attention, impulse control, motivation, judgment, which could actually influence eating behavior, increase energy intake, and lead to higher BMI in children. So to talk a little bit about interventions to improve sleep quality and quantity, really trying to address the question, can we increase sleep duration or improve sleep quality in children? And so, does it lead to improved weight status? In a systematic review in 2014 of sleep interventions, there were a few common approaches that have been shown to be effective in improving sleep duration and sleep quality. The first is comprehensive health education that includes teaching parents about developmental sleep needs and behaviors to avoid has been found to be a strategy in promoting sleep quality. The second strategy and potential intervention is you're working on bedtime routines in the home environment. There's good evidence to show that if the secular trends in shorter sleep durations that we are seeing are due to bedtimes, later bedtimes, perhaps promoting strict bedtime routines for children and promoting the kind of consistency of those routines in the home environment could assist in improving sleep duration and quality. We've shown in several interventions, including one with children 2 to 12 years of age, that both of these aspects are important. The focus on routines and consistency and schedules, but also the kind of realistic expectations of how much sleep children need. This is from one of our studies, Connect for Health, where we included sleep education for parents in an effort to improve BMI over time. And a study that we conducted working with low-income families on household routines, also including setting a bedtime routine and consistency of schedules, again, as a mechanism to prevent excess weight gain in children. Systematic review of sleep interventions, there's some good evidence to show that graduated extinction and mental presence are effective in improving sleep duration in children. infants, toddlers, and older children, parental presence while falling asleep is associated with later bedtime, long sleep onset latency, less total sleep time, and more frequent night awakenings. And so we've tried to do in some of our work, maternal child health work, and work with parents of infants, young children, is to promote this graduated extinction, behavioral technique that can be taught to parents to be utilized in the home environment. Involves some structured response to consistent bedtime and some time intervals that's increased weekly when children are allowed that ability to learn how to self-regulate their own sleep durations. In studies that we published a number of years ago, we worked with parents with infants birth to 6 months of age. We were working to improve sleep quality and quantity in an effort to prevent accelerated waking among infants. And we implemented a behavioral program among parents of infants that began in the first weeks of age, so between 0 to 3 weeks of age. We worked with families to try to avoid sleep associations and to promote infant sleep regulation. And we did by accentuating differences between day and night, ask a parent to try not to rock, hold, or nurse the infant to full sleep, but to try to set the baby down, still but still awake. With a focal feed between 10 p.m. and midnight. And again, as I mentioned, this promoting self-regulation of infant sleep by having the parents put the baby down in their crib, sleepy but still awake. In a month, one had shown that they were able to and growing well without any disruption in their growth. We asked the parents to begin to lengthen the time between feeds at night and slowly breaking the association between awakening and being fed. Also promoted establishing a calming bedtime routine. And through, and not just this, but in several other interventions that have been performed among parents of infants and very young children, intervention and others, and shown that these simple techniques that are begun early include health education and counseling and some strategies to promote regulation of sleep, even this early on, can actually improve sleep duration and quality in children. There's some practical recommendations that we teach our trainees and faculty on the discussion of sleep in children. There isn't a topic more pressing sometimes for families than how do they get their children to sleep better. And here, these are some very straightforward tips that we provide families and that we train our providers to encourage. Include, I've already mentioned, a consistent sleep schedule, consistent bedtime routines, teach child and allowing the child to fall asleep independently. Other recommendations, including avoiding caffeinated beverages, which I showed you earlier, is associated with being in that lowest quartile of sleep among infants and children. So a number of research gaps still remain in the literature, particularly in children relating sleep and obesity. Few studies providing evidence of underlying biological mechanisms in infancy and early childhood exist. I showed you a few of some potential mechanisms, but the pediatric literature still relies on much of the work that comes from the adult literature, and there are some things that are very specific to the life of a child and the experiences of a child that should encourage pediatric research in the investigation of potential mechanisms between sleep and obesity. Most studies have focused on sleep duration, and as Sanjay said, we've recognized more and more that sleep duration is only one aspect of sleep. There's sleep quality, there's timing, there's consolidation, there's regularity, and there's circadian alignment. Few studies in children have looked at these other aspects and components of sleep as they relate to obesity. And challenges, that objective measures of sleep characteristics are needed. In more and more studies, there's the use of actigraphy to measure sleep. Still many studies that depend on parental report. And I think a final research gap is that there's good evidence of the efficacy of behavioral interventions in improving features of sleep, but our studies testing the effects of those interventions on obesity are still few, and there's a paucity of studies in that area. So to finish up with just clinical implications, there's quite evidence now, as it is true in adults, that deficient sleep is associated with several adverse health outcomes in children. There's little risk to promoting good sleep hygiene to increase sleep quality and quantity and possibly to prevent obesity. And I just quote with that when the exposure is both common and modifiable, as obesity is, and the costly in terms of morbidity, mortality, and economics, even a small relative risk that we can potentially achieve by promoting sleep is of public health relevance. So I'll end there, and we'll take questions at the end. Thank you.
Great, thank you, Dr. Taveras. And as she said, we're going to take questions at the end. Please, as the presentations go on, feel free to include your questions in the question box, and we will get to them shortly. So now I'll introduce Dr. Michael Grandiner. Dr. Grandiner is a licensed psychologist certified in behavioral sleep medicine, director of the Sleep and Health Research Program at the University of Arizona, where he's an assistant professor of psychiatry, psychology, and medicine. His research focuses on downstream cardiometabolic and neurobehavioral risk factors associated with insufficient sleep in real-world situations, downstream social, behavioral, and environmental risk factors of insufficient sleep, and behavioral interventions for healthy sleep to prevent cardiometabolic risk. Dr. Grandiner.
Thank you, and thank you to the other presenters for being such hard acts to follow. So I'm going to be mostly talking about the role of sleep and obesity risk in adults. I'm going to try not to reiterate too much of what's already been said, and focus a little bit in terms of thinking about how to intervene on this issue. So the question I'm going to be addressing in this patient is, first of all, what constitutes adequate sleep in adults? Consequences of inadequate sleep in adults? What factors influence sleep in adults? How can adults improve their sleep? And how can we implement these in adults? First of all, what constitutes adequate sleep? Dr. Patel mentioned this quite a bit, but to provide a little bit of context, there's over 50 years of studies showing that sleep in the general population is associated with morbidity and mortality risk. In particular, short and long habitual sleep duration are typically associated with worse outcomes than whatever normative sleep is, though this definition varies across studies. The mechanisms for short sleep are much better articulated than the mechanisms for longer sleep, even though there is data suggesting potential impact of longer sleep. So here you can see a figure from the largest study that was ever done linking sleep duration with mortality. This is data from over 1 million U.S. adults from the Cancer Prevention Study 2 by Kripke and colleagues that came out in 2002, following people for about 10 years with about 30 covariates in the model, and you can still see this U-shaped relationship between habitual sleep duration and mortality hazard. Even though these data have existed for quite a bit of time, the field tended to lack general guidelines for sleep because of variable definitions of sleep, how sleep was measured, lack of precision in measures. Most of these large studies tended not to measure sleep very reliably. Recently, several guideline documents have emerged. So here's an example of 4 of them that have come out all within the past year or two. First, the American Academy of Sleep Medicine and Sleep Research Society came together to publish their first guideline statement, and they came to 7 or more hours. So around the same time, the National Sleep Foundation came out with their guidelines, which put recommended sleep for a typical adult at 7 to 9 hours. The American Thoracic Society had a document that came out recommending 7 to 9 hours. And recently, the American Heart Association also had a document that came out recommending 7 or more hours in line with the ASM and SRS document. So a number of guideline documents that have come out recently, and they tend to overlap pretty well. There's just some disagreement as to where upper limit should be for recommendations. First, consequences of not getting enough sleep. Two main domains are in the cardiometabolic and neurocognitive areas. So in terms of cardiometabolic disease risk, one of the best studied is metabolic disruption, and this can lead to things like changes in metabolic hormones, changes in insulin sensitivity, changes in diabetes risk, changes in weight gain, things like that. Energy imbalance, which seems to play a role here, and not just in terms of energy intake by changes in eating, but also some changes in energy expenditure. There are documented studies looking at sleep and inflammation, which I'll mention very briefly also. Inflammation is a cardiovascular disease risk factor, but also plays important roles in a number of metabolic pathways. Cardiovascular disease itself, in terms of hypertension, high cholesterol, heart attack, and stroke. The cognitive domain, this is actually an area that's received a lot of study, especially in laboratory samples, that doesn't have as much support in populations, because it's usually hard to study neurocognitive function at a population level. But there's quite a bit of data showing that impaired sleep, especially shortened sleep duration and extended wakefulness, are associated with impaired vigilance, which means decreased sustained attention, your ability to focus and maintain focus. Also areas as well, impaired decision making is one that's been studied relatively frequently, where irrespective of how quick you are and what your reaction time is and what your ability to focus is, your ability to make decisions and perform complex executive tasks is diminished. And some of these effects might interact on obesity, even though most of the studies of the neurocognitive domain stay there. And most of the cardiometabolic studies stay in a physiologic domain. There are important overlaps between the two, and I'll get to that. Just a relatively complicated picture that paints up one potential way to look at the role of sleep in obesity, where you have sleep deprivation, you have obesity, and you have a number of potential pathways, where you have a role of inflammation, you have roles of insulin dysregulation, you have a role of potentially decreased leptin and increased ghrelin, which would induce decreased satiety and increased hunger across 24 hours, which could lead to changes in increased food intake, leading to obesity, but there are other pathways as well. This is just to illustrate that there's lots of potential pathways between sleep deprivation and obesity, which make this particularly hard to study. In particular, I want to pull out insulin signaling because this is an area that's getting a lot of attention right now, especially looking at the role of molecular clocks in the insulin system. This figure is from a recent a recent review paper from Joe Bass's group at Northwestern, which was excellent in terms of laying out the state of the science in terms of the role of molecular clocks in insulin signaling. But in terms of real-world implications, so how is it that short sleep is related to obesity? Well, there's mechanistic questions, but there's also behavioral questions. So why is it that people are gaining weight? Well, one explanation is that they're eating more. So there are a number of researchers, including Marie-Pierre Saint-Onge at Columbia, and the Ninjas group at Penn, and a couple of others, and Ken Wright's group in Colorado, looking at this question. So this is data from what I think is the largest study that's been done, and probably the most generalizable, where there are about 200 people who were sleep deprived in the laboratory across 5 nights to simulate a sleep-restricted work week of 4 hours with a couple days of recovery. And they had unlimited access to food in the lab kitchen. And what they found was the control subjects didn't change their weight while in the laboratory, where the sleep-restricted subjects gained about 1 kilogram, so about 2 pounds. particularly interesting, and you can see in the figure on the right, that this differed based on demographics. So it was white women who gained the least amount of weight and black men who gained the most amount of weight in this study. One thing that's particularly interesting here was how eating patterns change, and this was a finding that's been seen several times now, at least in laboratory settings. People who are sleep deprived actually consume slightly fewer calories in the morning at breakfast, but if you see the figure on the left, you see the two groups. There's slightly less caloric consumption at breakfast, no significant difference in the middle of the day, but there's only one bar at night, and that's because that's the sleep deprived group consuming a little over 500 kilocalories on average at night, where the other group wasn't consuming anything because they were asleep. It seems to be something that's shown over and over again, where when you keep people up for extended periods of time, they start eating, and start eating between 300 and 550 calories per day, which might be what leads to this weight gain. The figure on the right shows potential differences in macronutrient content, but this is not as well established. What seems to be clear, though, across studies is that the craving is for energy-dense food. People start craving energy, even though there is a slight uptick in energy expenditure while being kept awake. The amount of calories that you start craving is much more than the energy needs, which creates an energy imbalance. Briefly, I want to mention inflammation. There's a number of studies in the laboratory showing that sleep deprivation increases inflammation, and there's also studies from the population that habitual sleep duration is associated with inflammation. Here's some data that we looked at in NHANES, a population level looking at CRP, showing a U-shaped relationship between sleep duration and CRP levels. On the you can see the relationship across hours of sleep, and on the right you can see the effects after adjustment for a long list of covariates, including potential sleep apnea and insomnia. So this isn't just an effect of untreated sleep disorders potentially. This is a potentially a sleep regulatory effect. There are a number of other studies that show similar results, that both short and or long sleep have variously shown up in different studies. The NHANES study was one of the most representative, which potentially is why it had both short and long sleep show up. But in the laboratory, sleep restriction is associated with elevated inflammation, and short sleep in the population is associated with elevated inflammation as well. What's not on here is there's a number of studies showing long sleep also in the population. In some of these and other studies have also shown elevated inflammation. In cardiovascular disease, to just go through this briefly, I want to show analysis of incident studies. So these are studies where people did not have hypertension at the beginning, and groups were either normal sleepers, usually 7 to 8 hours, or short sleepers, usually 6 hours or less, followed for similar time frames, showing that the hypertension across a similar time frame is about 20%. So you have a odds ratio of about 1.2 for developing hypertension. And similarly, here's a meta-analysis of studies of incident diabetes, showing an odds ratio of about 1.3. There are a couple of these meta-analyses out, and the numbers seem to be consistent, even though the exact studies that they include and how they run the sub-analyses is different, but these ranges seem to be pretty consistent across meta-analyses. So how do some of these cognitive effects, how do some of these cognitive effects play a role in obesity risk and interact potentially with these physiologic risks? When you think about obesity, at least from a psychological perspective, obesity is not just a result of physiologic changes. Obesity is a result of changes in behavior. And changes in behavior originate in the brain, not necessarily just in the physiologic systems and adipokines and endosystem. So this great study, it was small and provocative, and there aren't that many that have done something similar, but it looked at the overlap between changes in decision-making and changes in potential eating behavior. So this is a study where they had 23 young adults, not a very generalized sample, to be honest, in the lab, separated by 1 week. One they were well rested, another they were kept up all night. They were provided meals, and there was no difference, and you can see in the figure on the left, there's no difference between their hunger ratings when they showed up in the lab and even right before their scan. So they're in the fMRI. One scanner, they presented with images of food, and you can see on the right some images of food that were presented. And I don't know if you can see it very clearly, but this was the figure from the paper, and so some potato chips on a plate. I don't know who eats potato chips on a plate, but that was the picture. And subjects were asked to rate to what degree they wanted whatever food was presented. And so you can see the scale here between strongly do not want and strongly want. They just want to see, based on sleep deprivation, how likely were you to want healthy foods versus unhealthy foods. What they found was, if you were sleep deprived, you were more likely to want the unhealthy food. What's interesting is if there's no difference in the degree to which people wanted healthy food. Both groups said that was the right answer, that they were supposed to want healthy food, or they did want healthy food. But it was the sleep-deprived group that all said they wanted unhealthy food too, where the well-rested group did not say that they wanted the unhealthy food. So here you have a situation where potentially altered decision-making processes are playing a role in eating behavior. This mimics other data from laboratory studies showing that sleep loss on decision-making doesn't necessarily increase, say, risk-taking, but it changes the process by which you make a decision such that things you wouldn't normally decide to do start seeming like a good idea. The figure on the right shows that the degree to which they wanted the unhealthy food did correlate with how sleepy they were. So the more sleepy they were, the more likely they were to want the high-calorie food. So this is an example of how behavioral, neurocognitive, and physiologic changes in obesity risk might all come together. This gets to the question of why do people sleep the way that they do, and how could that potentially lead to obesity risk. So here's a model that's modified from a version we published a few years ago that we've been working from, where sleep really exists at this nexus between upstream influences, the individual level, things like your own genetics, but also your own behavior, psychology, your decisions, your beliefs and attitudes about sleep, which are embedded within social systems, things like your work, your home, your family, your socioeconomics, things that exist outside of you but play an important role in how you behave. For example, most people on this call would probably agree that their sleep in the last week was at least to some degree determined by either work or family roles, not necessarily your own beliefs about sleep. And still, the social factors are embedded within a societal level, things like public policy, things like globalization, 24/7 technology. These sorts of factors play a role in these social level organizations, which then filter down into the individual. Things like mobile technology in the bedroom, smartphones in the bedroom. There's a societal change that's filtering down into individual bedrooms. And then on the downstream end, you have all the adverse health consequences of insufficient sleep from obesity, but also including psychological disturbances, stress, and immune dysfunction. And of course, a reciprocal relationship. And just to talk about the importance of some of these, while clear there are physiologic risk factors associated with insufficient sleep, some of these risks might also be social. So I have some data looking at how, from the behavioral risk factor surveillance system, that foregoing care, that even if you have access to health care, foregoing care due to cost partially mediated the relationship between habitual short sleep and cardiometabolic disease risk based on the outcomes you see here. So from outcome to outcome, it varied, but in each case, there was a significant partial mediation between, for example, sleep and obesity. About 15 to 16% of the relationship, the cross-sectional relationship between sleep and obesity was accounted for by whether or not people were foregoing medical care. So it might not just be these physiologic pathways, but it might be that short sleepers are less likely to seek out other preventive care that could improve their health and reduce obesity risk. Another important factor here is a person's control over sleep. You think about real-world causes of insufficient sleep, a lot of times you're thinking about things like shift work, other responsibilities, and other potential sleep disorders where people don't necessarily feel control over their sleep. So here's some data we gathered from about 1,000 people in the Philadelphia area showing that people who are sleeping less are much less likely to say that they have some degree of control over their sleep, where people who are getting sufficient sleep do say, much more often at least, that they do have some control over their sleep. And this is very important when you're talking about interventions. The next question is, how do we get adults to improve their sleep? And when you get back to this question of what do we say? So how do we, the current state of the art right now is to say, well, your recommendation is about 7 to 8 hours, so you should get that. And if you can't, you should try harder. Which is sort of the equivalent of saying, you should cut down on your diet, you should stop smoking, and you really should cut down on your alcohol and exercise more. And we know from behavioral research that that's a relatively ineffective way to change behavior. Part of the reason is that these behaviors do exist in a context. And we need to much better understand the context of sleep to develop interventions that are actually going to work. And if someone feels out of control of their sleep, where only 12 to 13% of short sleepers feel that they have control over their sleep, telling them to gain control over their sleep and change it by will or by decision isn't going to be effective. We do. So first, we need to ensure we're screening and treating sleep disorders, as Dr. Patel mentioned. This is, you can't help someone sleep better if they have an untreated sleep disorder. From there, then we can potentially prevent poor sleep habits. That won't also help people sleep longer necessarily, but that'll help people make these healthful behavior changes and potentially impact on obesity. Very about sleep disorders, they're largely undiagnosed. Screening tools are readily available, and specialists are available for referral. It's just, they often don't get sent. I want to mention insomnia specifically, because it does overlap tremendously with insufficient sleep. Many people who are sleeping 6 hours or less also report significant experiences of insomnia, and it looks like the combination of the two is worse than either one alone. Symptoms are likely experienced by about a third of the population, with insomnia disorder, as defined in the DSM, are likely present in about a tenth of the population. Insomnia is associated independendly with obesity risk, and the first-line treatment should be cognitive behavioral therapy for insomnia. This is a multimodal treatment with decades of support that's endorsed by multiple leading organizations as the recommended first-line treatment, despite the fact that the vast majority of patients coming in with insomnia, A, get with insomnia treated as a symptom, B, have their insomnia treated as secondary to some other disorder, even though secondary insomnia, the evidence suggests that rarely is that the case, and C, if they're treated at all, it's usually with pharmacology that's not recommended as a first-line treatment. CTI is efficacious. It's effective across populations. It works in people who are depressed, have chronic pain, have PTSD, are cancer survivors. It works across populations, and the effects are lasting much more so than other approaches. Hypnotic medications are also an option for people who do well here, and there is use for them, but they shouldn't necessarily be considered first. Also, don't tend to increase sleep duration over time. Sleep apnea, Dr. Patel mentioned, so I'm not going to spend too much time on this, but it's extremely common, especially in middle-aged men, and it's largely undiagnosed. It's associated with obesity, more so probably than any other sleep disorder, and the treatment of sleep apnea interacts with obesity treatments as well. For example, weight loss is one of the few ways to actually improve sleep apnea without CPAP treatment. CPAP, though, is also it's efficacious, it's effective, has adherence issues, and the interaction between weight and sleep apnea plays a big role in the cardiovascular risk associated with sleep apnea. So you treat sleep disorders, then what? Well, you look at someone's sleep habits. So this is usually referred to as sleep hygiene. This is not a behavioral treatment for insomnia. This is just hygiene recommendations to get rid of obvious barriers to sleep. These are things like keeping a regular sleep schedule, getting enough light during the day and avoiding it at night, keeping your bedroom cool, dark, and comfortable, avoiding substances that will interfere with sleep, things like that. One thing that's very important here, it sort of borders the line between sleep hygiene and actual intervention, is something called stimulus control, which very briefly means that the bed is for sleep. And any things in bed that are not sleep, get them out of bed. If you're spending time awake in bed, get out of bed, and sleepy, get into bed. And that most insomnia exists as a conditioned arousal to the bed over time by spending excessive time in bed awake. And it's actually probably the only one of these recommendations that can actually potentially fix a sleep problem. But really, these recommendations are not enough. They're a good place to start. How do you get people to make healthy changes? So usually you have the protective benefits of sleep weighing against these social environmental constraints preventing sleep. So many people experience incentives for sleeping less, socially, culturally, even financially, potentially. These are things you need to weigh. So how do you consider helping people get more sleep? Unfortunately, there are no empirically supported interventions for insufficient sleep. Studies of insufficient sleep, but usually the interventions are, your study, we're going to extend your sleep and see what happens, not how do you get people to extend their sleep. So all I can talk about are some of the principles underlying what intervention might look like. So this is the health belief model, which has been well publicized in health behavior literature since the 60s. The point of the health belief model is if you're going to have someone engage in a healthy behavior, you need to identify the barriers to engaging that behavior. You need to identify the benefits of engaging that behavior, and you have to align that with the person's perceived susceptibility and the perceived severity. So if they don't think they're at risk, identifying barriers isn't going to be useful. So you have to marry all these together to develop a perceived threat and positive outcome expectations of engaging the behavior, remind them cues to action, improve their self-efficacy, which is their ability to believe they can actually do it, and that's how you can lead to a behavior. There's all these different components that you need to have in place before someone's going to engage in a healthy behavior. Another perspective is the integrated behavior model, where people engage in a behavior only after they decide to. And if they decide to, well, just like in the health belief model, you have your attitudes about what you think is going to happen, and how susceptible you are, how much control you have over your behavior. So you might need to increase your patient's control. But then also an important addition here is the idea of norms. What social pressures do you have? Does your boss feel weak if you get more sleep? Well, if that's the case, you're going to be incentivized to not. You have social pressures that you also need to take into account. What are your friends and family doing, what they believe? So all of the ingredients are important in terms of helping people understand how to make a healthy behavior. And you can't get someone to engage in a behavior unless they're ready. So the trans-theoretical model is basically a fancy way of saying, how ready are you to actually make a change? If you haven't even begun thinking of a change, if you're in this pre-contemplation stage, telling someone to do something is not going to be effective. You've got to get them at least agreeing to think about doing something first. And if they're thinking about it, you've got to get them prepared to do it, even if they're not taking the first step, before you try and get them into an action phase. So addressing an intervention where someone is in the spectrum has been shown to be very useful for other health behavior domains, and is probably going to be useful for sleep as well. So we impact on obesity risk, and I'll end there. So we've shown in a number of studies, there have been enough sleep studies that have shown that increasing sleep duration in habitual short sleepers can decrease 24-hour blood pressure, can improve insulin sensitivity, can decrease overall appetite for unhealthy foods, can improve sustained attention and decrease sleep pressure, can improve cognitive function. And of course, there is a potential risk of too much sleep, so how much is too much? But we do know that if we're able to make an intervention, we could probably demonstrate some general obesity risk. Make an impact. Screening and referral is important. If you have patients with sleep disorders, make sure they get treated. Screening tools exist. There are clinicians out there who are specialized in this. You don't have to do this on your own. How do you improve sleep behavior? Recognize that there are behavioral sleep interventions for sleep disorders, and although there aren't empirically supported interventions for increasing sleep time, there are some principles that you can think about or refer to somebody who's a behavior change person who can work with some of these. Increasing readiness and motivation, changing attitudes, intentions, and social norms around getting enough sleep, removing barriers, and making small, manageable changes. Are some unanswered research questions we should be focusing on for the future. First of all, what are the mechanisms linking insufficient sleep and obesity risk specifically? There are all these overlapping pathways. How can we tease them apart, and what's the most relevant, and what's the most useful place to intervene, and the most useful place to potentially mitigate risk? What interventions should we have for insufficient sleep? We don't have any good ones yet. What's the effect of sleep interventions on obesity, and what's the effect on other cardiometabolic risk factors, and how could we implement such an intervention besides just telling people get more sleep? And also, we need to consider the risk across populations. This is a theme that's come up a number of times today. The influence of sleep and obesity and cardiovascular disease disparities. So what is the role of sleep here? So we know obesity disparities exist. We know sleep disparities exist, and what's the role here? What is the role of sleep as a modifiable risk factor across populations, and the role of sleep disparities in health and disease? Developing tailored sleep interventions that take in the context that these different groups of people have into account. And very briefly, some policy implications. Sleep equity and healthcare access should be an important area. For example, access to healthcare among disadvantaged populations and the role of sleep care. Sleep and public safety is an issue. For example, obesity and sleep apnea in commercial drivers and police. Workplace reforms might be useful in terms of sleep difficulties associated with economic output. So we know people who aren't sleeping well perform less at work, call out sick more, and cost more in terms of healthcare costs. Healthcare initiatives, for example, what's the role of sleep in preventive care? Many programs have diet, exercise, and smoking and alcohol interventions, not sleep interventions. How should they be added? And also the role of telehealth, as there aren't nearly as many sleep clinicians as there are patients. How can we potentially develop policies that increase access to care? So I want to make sure that I thank all the people in our program and collaborators and mentors and people who funded the work of ours that we presented, and special thanks to the National Academies for hosting this. Thank you.
Oh, great. Thank you so much. That was another fantastic presentation. And now we're going to roll into the last presentation of our webinar, and then we're going to have quite a bit of time for questions and answers. So please do put your questions into the question box at the bottom right of your screen, and we'll be getting to them shortly. So finally, I'd like to introduce Dr. Chandra Jackson. Jackson is an epidemiologist and incoming Earl Stadman investigator at the National Institutes of Health in the National Institute of Environmental Health Sciences, with a joint appointment in the National Institute of Minority Health and Health Disparities. She's interested in translating epidemiologic evidence into interventions, policies, and practices that improve population health and address health disparities. Her latest research focuses on social determinants of sleep health as a major modifiable contributor to costly and preventable health disparities in chronic obesity-related conditions. Welcome, Dr. Jackson.
Thank you very much. Good afternoon, everyone. Thank you, organizers, for the invitation to participate in this very important webinar. It's certainly an honor to share this panel with such incredible clinicians and researchers. So just some overlap. I have been charged with the task of presenting on racial, ethnic, and socioeconomic disparities in disordered sleep and obesity. But describing the data, just conceptually, when you think about the relationship between sleep and obesity and how it may differ by race, it's important to identify the root causes or upstream factors believed to fundamentally contribute to racial disparities. For instance, the environment, both physical and social. We know that blacks or African Americans, for example, are and have historically been disproportionately represented in lower socioeconomic status groups. On average, blacks have greater exposure to potentially health-damaging environments and access to health-promoting goods and services that may influence both risk of suboptimal sleep and obesity. And we know that sleep is not entirely physiological or endogenous and is responsive either positively or negatively to exogenous factors like environmental light, noise, temperature, social or psychosocial stress, medication use, as well as quality and timing of both food consumption and physical activity, which, important to note, are differentially experienced by race and socioeconomic status. Genetics is another important upstream factor. It appears to account for 31 to 55% of a person's sleep duration, with behavior and environment accounting for the remainder. Interestingly, a study that needs to be replicated suggested that African ancestry was associated with acquiring less slow-wave sleep, which, as mentioned by previous speakers, is important for physiological restoration. But we know that race is a social construct and that phenotypes like skin or eye color are not innately linked to health or lifestyle-related disease, but could as proxies for groups with more or less social, and economic obstacles to health. Actually, the Human Genome Project revealed that there's more genetic diversity within these socially constructed race categories than there is between them. So ultimately, genetics influences sleep in all individuals, but it's unlikely to be the main reason for differential risk of suboptimal sleep and obesity between races. And certainly, there's also gene-environment interactions, so epigenetics, where gene expression can be modified without altering the person's actual genetic code itself. So this may contribute to racial ethnic disparities in the sleep-obesity relationship, since blacks and whites have intergenerationally and still are exposed to quite distinct environments throughout their lifespan. So acknowledging that there could be a bidirectional relationship where obesity could also affect sleep, using a direction where mediators like biological mechanisms and behaviors along the pathway between sleep and obesity are likely affected by the upstream factors just described, which could be contributing to the well-observed racial differences in risk, prevalence, and severity of both sleep disorders like obstructive apnea and obesity. On data from the epidemiological and clinical research literature, there are important disparities in both sleep and obesity independent of each other. In socioeconomic status, as typically measured by income, education, occupation, and sometimes wealth, the SES individuals generally have higher rates of extreme sleep duration, considered either too short or too long. Low SES groups also have higher rates of low sleep quality, as well as some sleep disorders like obstructive sleep apnea. Sleep studies research is in its infancy, but there is evidence suggesting that greater and unique exposure to neighborhood, occupational, and psychosocial stressors, as well as environmental exposures to, for example, tobacco, allergens, and pollutants, may adversely influence sleep quality and duration, and also exacerbate disorders like obstructive sleep apnea. Studies also suggest that the impact of neighborhood disorder on either psychosocial distress and measures of health status are at least partially explained by the impact of neighborhood characteristics on short sleep duration or poor sleep quality. With regard to racial ethnic disparities in sleep duration quality and the most common sleep disorders, obstructive sleep apnea and insomnia, I will describe some of the most salient disparities, but have listed references at the bottom of the slide for those interested in a more comprehensive overview for all minorities, mainly in the U.S. So compared to whites, African Americans or blacks are nearly twice as likely to report short sleep, with black men being the most likely. Blacks are also over 60% more likely to report long sleep. There are apparent differences in sleep architecture by race. For example, blacks have consistently been shown to experience less deep sleep, slow wave sleep, and that's stages 3 and 4, and more light sleep, stages 1 and 2. Blacks tend to take longer to fall asleep and have less efficient sleep, meaning less time in bed actually spent sleeping despite trying. Although there are believed to be many undiagnosed cases of obstructive sleep apnea, as mentioned by previous presenters, especially among minorities, the prevalence is highest among blacks. Black children, alarmingly, have a 4 to 6 times higher prevalence of obstructive sleep apnea than white children. Blacks also experience more severe health consequences in that they are significantly more obese and have higher rates of hypertension at the time of sleep apnea diagnosis. Identified a stronger association of increasing BMI and waist circumference with sleep-disordered breathing among Chinese individuals compared to whites, blacks, and Hispanics. Regarding insomnia, the results are mixed, but whites appear to have the highest prevalence. Estimates may be biased due to methodological issues related to different definitions of insomnia being used and over-reliance on self-reports and the need for healthcare professionals' diagnosis, requiring healthcare and utilization, which we know differs by race. Independent of sleep, obesity rates, as we know, are higher among blacks and whites compared to whites and Asian Americans, and the inequity is highest between black and white women, with approximately 57% of Black women being categorized as obese compared to 38% of white women. This figure, also using nationally representative data from the National Health Interview Survey, illustrates through smooth lines of mean body mass index for Black men with the solid lines and white men with the dashed lines by level of educational attainment that the obesity epidemic has not affected everyone equally, and that there is socioeconomic variation even within racial categories. For example, only Black men with greater than a high school education had a consistently higher mean BMI than white men of any level of education across the study period, while mean BMI for Black men with less than a high school education, represented by the orange line, remained stable across the study period. So why do these disparities exist? So in the next slide, discuss a pretty comprehensive conceptual framework to help us organize our thoughts and ideas about the complex array of factors that likely contribute to racial, ethnic, and socioeconomic health disparities. And so developed by National Cancer Institute's Centers for Population Health and Health Disparities, I like this particular framework because it draws upon the realization, as Dr. Granger mentioned, that individual behaviors like sleep are influenced by complex and dynamic interrelations between individual and his or her physical and social environments, also affected by even more upstream or root causes of disparities like modifiable social conditions and even policies. So acknowledging that a person's biology constantly interacts with their environment across the lifespan, I'll discuss some examples of proximal, intermediate, and distal determinants that are relevant to sleep and obesity and likely contribute, to the sake of this conversation, to disparities in well-known consequences of obesity like cardiovascular health outcomes. And so with proximal or individual determinants of health, you see here that obesity is listed as a biological response to sleep as an individual risk behavior. And that many individual-level health behaviors like sleep hygiene, for instance, one's bedtime routine and use of technology before bed, as well as obesity-related behaviors like nutrition and physical activity, can influence one's sleep duration, quality, and timing. And it's well known that these characteristics differ by demographics like ethnicity and socioeconomic status. And continuing with proximal determinants, this figure illustrates how sleep restriction may lead to the biological response of obesity. So to highlight two pathways, and Elsie certainly mentioned these important pathways, not getting enough sleep may upregulate the hormone ghrelin found in the stomach, which is associated with hunger. And not getting enough sleep may downregulate leptin, which is a hormone secreted by adipose or fat tissue that's associated with satiety or feeling satisfied after a meal. These appetite-regulating hormones may act in concert to increase the risk of weight gain and eventual obesity. And so actually before I move on from proximal determinants, I want to mention that if we in science and public health continue to focus the vast majority of our efforts ending on this end of the spectrum to understand biological responses to individual risk behaviors, how they differ by demographic groups like race, then we'll continue to limit our ability to address preventable health disparities because, as illustrated by this framework, the fundamental causes are going unaddressed or under-investigated. So ultimately, biological investigations are certainly necessary, but insufficient for health disparities researchers and those interested to be optimally effective. So I believe that intermediate determinants of health, like neighborhoods, represent the physical and social environments where upstream distal determinants, like socioeconomic status or discrimination, are realized by linking the environment to individuals and thereby influencing more proximal determinants like sleep-related risk behaviors as well as biological responses to those behaviors in this case, obesity. For example, you can imagine that neighborhood and housing disadvantages like inopportune light and noise, any neighborhood disorder could influence sleep health and contribute to health disparities. Obesity could be affected by neighborhoods' walkability in order to engage in functional or leisure time physical activity, as well as the food environment, like food deserts being more prevalent in low-income minority communities, therefore contributing to increased risk of obesity. Environments as an intermediate determinant also appear important for sleep and obesity disparities, as mentioned by previous presenters, because long work hours, night shifts, work with stress, and impaired work-life integration, which are differentially experienced by race, can influence behaviors like sleep, physical activity, and nutrition. And in one of our studies, we found when looking at prevalence of short sleep duration by occupational class across various industries of employment, that short sleep generally increased with decreasing professional roles among whites, but the opposite was true. It was true for black professionals, where they had the highest prevalence of short sleep of anyone, including their non-professional counterparts. And so this shows social patterning and a relationship that differed by race ethnicity. And so in a separate study, we also found evidence of important socially patterned disparities in obesity by occupational class across employment industries. So, as one important example of an intermediate determinant, social relationships, family routines, and parenting styles could also influence sleep early in life, because children usually take on the sleeping routines of family members. Structural factors like parental work schedules could also influence children's sleep, especially if a parent works multiple jobs, including night shift, and isn't home, for example, to enforce sleep rules or curfews. And so this type of research, as Elsie mentioned, is being conducted. We found, conducting a literature review, that adverse childhood experiences like physical and sexual abuse associated with an independent risk of sleep disorders in adulthood, which likely occurred through several pathways related to disrupted neurodevelopment and failure to develop a healthy sleep schedule. And it's important to note that adverse childhood experiences have also been associated with an increased risk of obesity. And so determinants like poverty, socioeconomic status, and discrimination are considered fundamental or root causes of health disparities, because their influence contributes to variation in health and disease. For example, discriminatory practices that help funnel certain demographic groups into impoverished neighborhoods with crime and stress because of poverty and poor housing conditions could contribute conceivably to sleep and obesity disparities, especially compared to groups less affected by a particular discriminatory policy. Discrimination is an important distal determinant because it shapes societal policies, practices, and norms in ways that can affect obesity across the lifespan through inequities in access to, for example, higher education, economic opportunity, healthy foods, and health-promoting behaviors like sleep. Racial discrimination is actually considered a key determinant of racial disparities in health in general, and sleep may be an important understudied mechanism by which these social factors actually get under the skin to influence disparities in obesity-related health. With regard to actual scientific evidence, a study found that blacks who reported greater levels of racism-related vigilance or bracing themselves in anticipation of experiencing racism had greater levels of sleep difficulty compared to whites. There's also data suggesting that perceived day-to-day interpersonal racial discrimination is associated with greater sleep disturbances and daytime fatigue, as well as acquiring less deep sleep. Genetics in this study showed small, non-significant associations, while whites showed no association between racial vigilance and sleep difficulty, demonstrative of social patterning. A study found that multiple levels of racism, including interpersonal experiences, racial discrimination, and the internalization of negative racial biases operate jointly to accelerate vascular aging as measured by telomere length. In future directions, researchers should, when possible, conduct prospective studies to establish temporality between sleep and obesity, because it's well known there's a bidirectional relationship, as well as randomized controlled trials to provide strong causal evidence. We should also use repeatedly assessed objective measures that are standardized across the studies, incorporate sleep measures in existing laboratory, clinical, and epidemiological studies, as well as incorporating social determinants of health. In addition to increase minority research participation and explicit a priori investigations by race, researchers should pursue transdisciplinary approaches to studying disparities in the relationship between sleep and obesity. For instance, having social epidemiologists collaborate with clinicians and even bench scientists to elucidate the mechanisms from a societal to biological perspective. And so the non-exhaustive research topics include investigations of social determinants of sleep health and obesity risk to complement the clinical research and bench science being conducted. The impact of early life exposures because of the apparent greater lifetime burden of sleep disorders experienced by low-income minority individuals, especially Black and Latino children. Seek to understand racial differences in time use and daily stressors or hassles and the impact of sleep. American Time Use Survey may be particularly useful for the type of research question or topic, as well as investigations of race and versus race, because there's some evidence suggesting that when racial groups actually live under similar conditions, disparities are minimal, and this does include obesity as an outcome. Researchers are in hot pursuit for identifying biomarkers for acute and long-term sleep deprivation, as well as certain sleep disorders, which could prove helpful for health disparities research as well by helping to elucidate elusive mechanisms. Pioneering the exposome movement by focusing on the integration of external and internal exposures, which could be highly innovative for health disparities researchers by making it possible to investigate how social and physical environmental factors, again, under the skin to influence sleep and subsequent disease risk. And lastly, conducting implementation and dissemination research to increase public awareness of the importance of sleep. And so with regard to policies and structures needed to address disparities, is admittedly blue sky thinking, but if I were a decision maker interested in implementing policies and structures to address disparities in the sleep-obesity relationship, I would, as touted by the Centers for Disease Control, focus on evidence-based policies, systems, and environmental improvements. Again, because if we're actually going to address disparities, we need to focus on the upstream root causes of those disparities. And so the list is unexhaustive, but I would recommend incorporating health impact assessments in policies, whether local, state, or federal, because all policies affect health. In all policies, incorporating health equity assessments that aim to address discriminatory policies or practices, whether intentional or unintentional, and the unequitable distribution of power and resources. I also recommend implementing, evaluating structural and individual level interventions that are culturally relevant and community-based. Focus on intervening. I'm sure you've heard this before, where people live, work, and play and worship in ways that make that healthy choice the default choice among both individuals and decision makers. For example, improving the built and social environments of neighborhoods, housing and work, even improving structural factors like school start times, for which evidence of its effectiveness in improving sleep and reducing injury and mood disorders is growing. And so since sleep literacy is so low in the general population, but perhaps especially in some minority communities, focusing on increasing public awareness of the importance of sleep by, for example, discussing the science behind its impact on weight, while prioritizing vulnerable populations in terms of delivering this information, might prove quite effective at addressing health disparities. In addition to integrating sleep into medical training, increase sleep specialists in federally qualified health centers. So while there certainly are sleep specialists, we find that low-income individuals are even less likely to receive a referral, but we know that low-income minority individuals get health care at federally qualified health centers disproportionately. In conclusion, we know that sleep and obesity disproportionately impact low-income individuals and racial ethnic minorities. Sleep and obesity are socially patterned and embedded in physical and social contexts that are influenced by upstream social conditions, as mentioned by Dr. Granier. Social determinants of health are believed to be important major contributors to disparities in both sleep and obesity. Earth exposures or experiences appear particularly important in terms of addressing the lifetime burden associated with sleep and chronic disease. Racial ethnic groups should not be studied as a monolith wherever possible, because important socioeconomic variation within racial groups exists. Sleep is modifiable and interacts with other behaviors. In fact, it could be considered the first behavior in a domino effect, in that focusing on improving sleep could make it easier to improve other habits related to nutrition and physical activity, for which we've had limited success. But this would certainly take a lot of future research. Sleep become necessary to implement and evaluate sleep-relevant, place-based environmental interventions in hopes of improving population health overall while addressing health disparities. And so thank you very much for your time and attention.
Thank you so much. That was excellent. And now let's move right into some questions, and we have a whole bunch of great ones. So let me start with Dr. Patel. Does sleep cause weight loss? And perhaps you can answer that, two parts of that. One, does treating sleep apnea cause weight loss? We have interventional data on that. And then does treating non-apnea sleep disorders lead to improved weight?
Treating sleep apnea, we have an answer for it. Does not cause weight loss. It actually causes weight gain. Some hypotheses on why that is. I think the most likely explanation is that struggling to breathe against a collapsed throat at night, you actually burn a lot of calories using your breathing muscles. And when you relieve that by treating the sleep apnea and you sleep more soundly and breathe more normally, you have reduced your energy expenditure. And so we typically, there have been meta-analyses that show that you gain probably about half a kilogram on average when you treat sleep apnea. Just treating the apnea without dietary intervention as well. In terms of whether improved sleep inside of sleep apnea, to getting people to sleep longer, whether that lowers weight, that is the big question, and I think that's the question we need to try to answer. We have tons of observational data that show that there's a risk factor, but we don't have the interventional data. People have tried to do some trials. The problem is in the real world, the interventions that people have used have not been sophisticated, as Dr. Gradner suggested we need to be, and they simply tell people you should sleep more. They don't, and so until we have a more sophisticated intervention to actually get people to sleep more, we're not going to be able to answer the question.
And Elsie, can you answer the same question regarding children?
So I was actually on mute, but I was going to add to what Sanjay said. The studies haven't been designed in that way, or sleep is a multiple component, intervention component with other health behaviors being addressed together. So it's hard to answer this question of, if you get children to sleep more or better, does it lead to improved BMI or weight gain? I think it's safe to say that studies that have included as a multi-component intervention, sleep promotion, and promoting sleep quality and duration have been effective. But where we can isolate the effects of sleep in those interventions is still not determined, and not the way the studies have been designed to date.
Thank you. Okay, so on the clinic side, I'm wondering how sophisticated are clinicians in asking about and screening for sleep problems and sleep apnea? And again, here I'm curious from Dr. Patel and then Elsie in adults and children.
In general, physicians are not very good at identifying or screening for sleep apnea. Part of that is a knowledge deficit. There's very little sleep education in medical school training, and then also not great screening tools developed yet for general populations. I think some common sense things that people could do to just see if there's important sleepiness. Just asking about whether people have had trouble keeping their eyes open while driving would help identify life-threatening sleepiness. But the recent polls of online of patients with sleep apnea, asking them how long from when they started having symptoms till they received a diagnosis, and the mean duration was 10 years. So I think we can do better than that.
I'd like to add, this is Mike Renner here, that the available evidence from sleep interventions, at least for sleep disorders, is that sleep interventions tend to be easier than dietary and exercise interventions. Especially in the insomnia domain, we can get dramatic changes to sleep, and also in the pediatric world, the pediatric behavioral interventions for sleep tend to get much more reliably positive efficacious results faster than diet and exercise interventions, and I think that's an important point to make as we're run up against a lot of walls in terms of helping people lose weight by changing diet and helping people lose weight by increasing physical activity. But sleep may be an easier target, and some successes in sleep. I mean, as a question, could success in improving sleep improve adherence and ability to make changes in other domains as well? I mean, that I think is a separate issue.
Yeah, I think.
To talk about the pediatric component, I think many pediatricians are kind of forced to address the question because it's top on the list of things that parents want to talk about. I think in pediatrics, the bigger concern or issue is non-standardization of the counseling and education that's provided. I think you can see, 5 different clinicians with 5 different recommendations, and so I think it's not necessarily an issue of awareness of the importance of it or even asking about it. I think a concern and maybe an opportunity in pediatrics is to increase the counseling that clinicians and the standardized counseling and recommendations for clinicians to use with their families.
Yes, say one caveat to what Dr. Grish said, going back to his earlier slides. The awareness of preventions really depends on the person wanting to change. So what presents as a patient with insomnia or the parent who's with the child presents, I think it's much easier to get that sleep intervention done. Whether that can be similarly in sort of the average person who doesn't believe they have a sleep problem, I think is where we really need to work.
Thank you. Elsie, let's stick with you here. So there's a question. I have a 7-year-old daughter who has never been a good sleeper despite enforcing regular bedtimes and consistency. She's inactive. Is there any research on why some children are just not good sleepers?
I want to direct that actually to the sleep researcher, to Dr. Patel. I know there are individual differences in sleep, and whether those are genetic or environmental, I think there for sure are. I'm not as familiar with some of the genetic differences in sleep preferences and patterns. Sanjay, do you have more information about that?
I think, as Dr. Jackson said, there certainly is some genetic basis for this, but I think there are also, to what extent these are preferences and just trying to put a child to sleep at the wrong for them, or early behavioral earth events that have affected their sleep, or epigenetics. I don't think it's all been worked out yet.
And much more information about what exactly the interventions were that were tried based on what the sleep diaries looked like. It's to know whether what done might have been the optimal thing to do. But there are pediatric sleep specialists with behavioral training that out there might be able to better answer that.
Yeah. Elsie, I'm going to go back to you for one more question. So regarding graduated extinction to help young children learn self-regulation of sleep, many parents worried that there may be harms of not responding very attentively to their children at night. Can you speak to that?
For sure. And the other thing I wanted to mention, I saw there are also some questions about sleep training newborns. And I should probably emphasize that some of the work that has been done in kind of promote sleep prevention and promotion in kind of the newborns and birth to 6 months, it's not sleep training. It's really and educating and counseling families on the sleep patterns and sleep behaviors that can lead to better sleep quality and duration in their infants. And the other question that came up is that at odds with breastfeeding? And argue that it shouldn't be, that the same counseling that we would give to a family around sleep promotion and quality does not in and of itself encourage in any way feeding on demand or nursing. You asked a really good question about the graduated extinction, and what I have learned in many opportunities to do and to work with families in this area is that every single child is different, and the approach is not one approach fits all. There are some children that do not do well, or parents who do not do well with these approaches of kind of locking the baby in a room. And I honestly have never heard personally of a pediatrician tell a parent to do that. And I do think that some of these approaches have to be tailored, have to be individualized, have to be negotiated with families. What's a parent comfortable with? What are some alternatives to this graduated extinction with parental presence, without parental presence? And so I just want to emphasize there that it's not a one-size-fits-all, and it shouldn't be a contentious or a thing that is negotiated with a parent. It should really be based on comfort and what the parent is able to do in this kind of sleep training when there is a perception of a sleep problem.
Dr.
Hi, this is Sandra, and I actually just wanted to add that from an evolutionary perspective, it has been quite recent that we've started to separate parents from their children in terms of the sleeping environment, and it was actually in response to sort of European interest in creating more privacy for parents. And so, evolutionarily speaking, it may not be so natural actually to separate children from parents at a particular age.
Dr. Let's stick. Is data explaining why Black children have a 4 to 6 times higher prevalence of obstructive sleep apnea compared to white children?
Oh, question. So I am unfamiliar with research that has asked that question explicitly, but I've certainly read research, for example, something published in Behavioral Sleep Medicine that has shown children who live in neighborhoods with economically deprived environments and social fragmentation, so essentially poverty and instability, that they are more likely to have less sleep and poor sleep efficiency. Didn't necessarily investigate risk of obstructive sleep apnea, but and clearly this is an important topic for research, but we do know that Black children are much more likely to live in concentrated poverty and to be obese at a young age, and to also, as mentioned by Dr. Tavares, have televisions in the room, and so may have a profile that could increase their risk of obstructive sleep apnea, in particular early in life, which again contributes to a longer lifetime burden of sleeping disorders and therefore potentially chronic disease. So again, I'm unfamiliar with this question being answered explicitly, but there's certainly data suggesting that a person's physical and social environment could be an important contributor.
That the strongest risk factors in children for sleep apnea are obesity and enlarged tonsils and adenoids. African American children clearly have a higher prevalence of obesity, but they also appear to have a higher prevalence of enlarged tonsils, certainly suggesting that might be related to environmental exposures, as Dr. Jackson said, from allergens and air pollution.
Okay, last question we have time for. In addition to sleep, another topic that we've heard a lot about with respect to obesity is the microbiome. So there's a question concerning whether we think the microbiome may serve as a mechanistic link between disordered sleep and obesity. Anyone have some thoughts on that?
Yeah, it's a really exciting area. It's been difficult to study because studies on that the microbiome in an individual actually changes by time of day. But that's a number of labs are pursuing. Some animal studies from David Gazal's group at University of Chicago showing that fragmenting sleep alters the microbiome in animals.
Just to piggyback on what Dr. Patel mentioned, I mean, this is a very exciting area of work. I think it's a plausible hypothesis because when you consider the role of sleep in so many physiologic functions, you look at the list, it's very long and diverse because, you know, in many ways the whole body sleeps, and sleep plays so many regulatory roles. It actually less plausible to deny that it probably has any role in something that important jobs as the microbiome in terms of regulatory processes.
There was just an article. So Sanjay's right. Some of the work that has been done have been in animals. There's maybe a handful that have been adults where they sleep restrict adults and then look at any alterations in the microbiome and profile. From what I can see, there aren't omics studies yet to understand the function of the difference, if any, in the composition of the microbiome and changes. There's also a study that I'll post on the site that just came out earlier this month, showing that in human and rats, microbiome composition is actually maintained following sleep restriction. The other area is circadian misalignment and whether misaligning a person's circadian rhythm is associated with microbiome alterations. I would say both of those questions, both sleep restriction and circadian misalignment and how they affect the microbiome are really interesting.
I agree. Well, thank you all, and thanks everyone for joining in on the webinar. Upon exiting, you'll be redirected to a short survey. Please take a moment to fill out the survey and let us know what you thought of the webinar. Your feedback is very important to us. A copy of today's recording and the slides will both be posted to the Roundtable's website within a week or two. And with that, I want to thank our speakers, Dr. Sanjay Patel, Elsie Tavares, Michael Grandner, and Sean Jackson. Thank you again for participating, and everyone have a great day and a great weekend. Bye, everyone.